So, good afternoon, everyone. Today, my privilege and honor to present my residency thesis with the title The Application Value of Right Ventricular Pulmonary Artery Crippling to Predict Exercise Intolerance as an alternative to 6-minute walk test in patients with chronic heart failure with reduced ejection fraction. There are 5 objectives in my presentation: background, the aims of the study, methodology, results, and conclusion. So I want to begin with a little bit about epidemiology of heart failure. So an estimated of around 64.3 million patients living with heart failure worldwide, and HFrEF accounts for around 50%. So in developed country, the prevalence of heart failure around 1 to 4%, and in China, in Asia region, so in China is around 1.3 to 3.5%. The burden of heart failure is still really high, especially in the country with the region of low to middle societal demographic index. So So that's why cardiac rehabilitation program in heart failure is so important, right? So what is the cardiac rehabilitation? Generally, it has 5 domains: risk factor modification, diet and nutritional counseling, education on comorbidities, psychosocial assessment, and exercise. So generally, cardiac rehabilitation program itself do not um, improve prognosis of patients with heart failure, but also it can reduce the rate of readmission. Today, I just want to focus more on exercise. So when we assess the exercise in patients with heart failure, we can quantify symptom and size, predict prognosis of heart failure, assess the treatment, and more important, exercising patients with heart failure can bring the benefits. What are the benefits? It's not only benefits in the cardiac, but also in the kidney, the hematology, the metabolic, the MSK, the vascular, and the lung as well. So exercise testing in patient with heart failure is so important. There is numerous modality to evaluate exercise capacity in patient in the clinical practice, but traditionally CPET and 6-minute walk test is a more common use. CPET, cardiopulmonary exercise testing, is not um, so popular because it's not always available in any center, but also it is so expensive compared to 6-minute walk test. 6-minute walk test is more cheaper, reproducible, and um, um, it's easier to perform in the clinical practice. So there is some indication um, of 6-minute walk test. We can apply 6-minute walk test for lung disease and also cardiac disorder, COPD, lung transplantation, pulmonary hypertension, peripheral artery disease, and heart failure. According to a clinical trial was published on European Heart Journal in 2017 with more than 100 HFrEF patients, and after long-term monitoring around 7 years, indeed, 6-minute walk test is a predictor of cardiac death. It means that in patients with abnormal 6-minute walk distance has significant higher risk in cardiac death compared to normal 6-minute walk distance. And the cutoff is 340 meters. Right ventricular pulmonary artery crippling, what does it mean? So generally, right ventricular pulmonary artery crippling is the relationship between right ventricular contractility and pulmonary resistance, vascular resistance. So here is the picture that elucidated the concept of ventricular elastin and arterial elastin, or representative RV contractility and RV afterload. So, right ventricle truncular pulmonary crippling can be accurately measured by catheterization. But in clinical practice, there are several surrogates for right ventricular pulmonary crippling, the TAPSI, PEPS ratio, S prime, SV, RVSP ratio, or FAC RVSP ratio. So the aim of the study to describe the clinical characteristic, right ventricular pulmonary crippling, assessed by echocardiography and exercise capacity, measured by 6-minute walk test in patients with heart failure with reduced ejection fraction. Number two aims to assess the correlation between right ventricular pulmonary crippling and 6-minute walk test in patients with HFrEF. Study design. This is a cross-sectional study, prospective, 39 patients with heart failure with reduced ejection fraction in 108 Military Central Hospital, Hanoi, Vietnam, from December 2020 to October 2023. Initially, in the enrollment process, 55 patients were assessed for eligibility. 10 patients did not meet entry criteria, so we excluded them. 45 patients entered to the phase of doing echocardiography and 6-minute walk test, but unfortunately, 6 patients were excluded because they are unable to complete 6-minute walk test. So eventually, we have 39 patients underwent the study. Research facility, we use the Philips IE33X metric ultrasound machine to quantify the echocardiography parameter. We also 6-minute walk that took place in the general cardiology ward with a walking course 30 meters in length with and marked with the line, and the line is marked by interval of 5, 10, 15, 20, 25, and 30 meters. Inclusion criteria, heart failure, NIHA 1 to NIHA 3. Let me clarify a little bit. So we recruited the HFrEF patient with NIHA 1 to NIHA 3. But the patient with NIHA classified as NIHA 3 underwent echocardiography and 6-minute walk test once they stabilize. It means that when they reach to the NIHA 2 during their hospitalization, LVEF under 40%, patient able to walk on the flat floor and agree to participate in the study. Exclusion criteria, planned coronary revascularization, ICD, CRT, recent unstable angina MI. Patient underwent major organ transplant or intend to transplant. Anemia with hemoglobin under 10, body index, mass index in more than 50, acute uncompensated heart failure, and patients are unable to walk on the flat floor. Here's a NIHA classification. So NIHA 1, no limitation of physical activity. The ordinary physical activity does not scare any symptom. NIHA 2, slight limitation on physical activity. Ordinary physical activity causes the symptom. NIHA 3, marked limitation of physical activity. Less than ordinary activity resolve the symptom. NIHA 4, unable to carry on any physical activity. I wanted to talk a little bit about what we do on echocardiography and 6-minute walk test. So we use the parasternal long axis view to quantify left ventricle dimensions. And LVEF was quantified by Simpson method via 4-chamber and 2-chamber view. Left ventricle diastolic function was evaluated by measuring E prime, septal, and lateral. E way and A way was measuring through the mitral inflow. And also we calculate the E over E prime ratio. along with Levy. Right ventricular parameters including TAPSE, pulmonary systolic pressure, and S prime. So, and then we calculate the right ventricular pulmonary crippling parameter. Consists of TAPSE, PASP, FAC, RVSP, S prime RVSPs. So the formula for RVSP is force where peak tricuspid regurgitation velocity square plus right atrium pressure. But make sure that we understand several pitfalls when we do the echography. Generally, for patients with severe tricuspid regurgitation, pulmonary stenosis, and poor signal quality of TR also affect the result of pulmonary systolic pressure and TAPSE. Normally, TAPSE and S prime is angle dependent. About 6-minute walk test. At the beginning of the test, we assess the patient, including assessing the vital sign, the symptom. And after we finish the test, I also documented the 6-minute walk test distance and percent predicted distance. Statistical analysis. About descriptive statistics, the quantitative variables will be checked for normal or non-normal distribution using histogram. For normal distributed quantitative, the description given by mean and standard deviation. For non-normal distributed quantitative variable given by median and interquantile range. For categorical variables given by frequency and percent. Inferential statistic, two means can compare using independent sample t-test for normal distribution and mean Whitney for non-normal distribution. Pearson and Spearman also used to assess the correlation between quantitative variable. Linear regression models also used to determine to assess the relationship between right ventricular pulmonary artery pressure and 6-minute walk distance. P-value under 0.5 is considered statistically significant. We're also using ROC curve to find the sensitivity, specificity, and the cutoff point for predicted value of quantitative variable. Here is the result. We divided the population sample in two groups, under 340 meter and above 340 meter. We based on the clinical trial I talked about the prognosis of patients with 6-minute walk after 7 years monitoring. So most of patient is a male, right? 77%, and there are a statistically significant difference between two groups. But about the age characteristic, the mean age around 63.7 is quite homogeneous to the trial of Legris, the mean age around 61. Signs and symptoms. Majority of the patients have the chest pain and orthopnea, around 20%, 18 to 20%. NIHA classification. Majority of the patients have NIHA 1 to NIHA 2 upon admission. 18% patients have NIHA 3, but at the time of 6-minute walk test and echography, all of the patients at NIHA 3 was converted into NIHA 2. We compare to the trial of Stefano Gio, NIHA 1 and NIHA 2 accounts for 77%. The other trial is Lina Bosch, 100% with NIHA 1 to NIHA 2. Here's the comorbidities. Majority of comorbidities of the patient in our study is hypertension, diabetes, and prior CABG and BCI, right? Really high, 44% patient have hypertension. Compared to the trial of Legris, hypertension accounts for 49%, type 2 diabetes around 34, and CABG BCI 43. So it means that majority of the patient related to uh, to comorbidity is high risk for ASCVD. Here is the left ventricle echocardiographic characteristic. The mean of LVEF by Simpson method is 32%, and there are statistically significant difference between two groups. Compared to the clinical trial of the leg risk, our population sample have the higher LVEF compared to leg risk trial. It is 26.6%. LV diastolic function, there's no statistically significant between two groups. Right ventricular parameters. This is a really important slide. We show the right ventricular pulmonary crippling characteristic. There's no significant, statistically significant between two groups. When we compare the right ventricular pulmonary crippling characteristic in our study to other study, we see that TEPSI PEPS ratio is more higher. We can compare to trial of Legris, Bruno, and Lena with 0.64. 6-minute walk test distance characteristic. The mean of 6-minute walk test distance is 356, and and compared to the trial of R-Line is more higher compared to the trial of the R-Line, and with Legris is quite similar. Um, this is a really important outcome. So with the objectives, we determine the correlation between right ventricular pulmonary crippling and 6-minute walk distance. But unfortunately, result came up with the lack correlation between right ventricular pulmonary crippling and 6-minute walk distance. In contrast, in the study of leg risk was published in 2022, TEPSI PEPS ratio showed the correlation. We can explain this different is may divide in two things. First one is population sample and how we design the study. Our study have a very small population sample, around 39, but in the leg risk studies, more than 100 patients have brought. One of the interesting things is when we perform the univariate analysis and multivariate analysis, we found that right ventricle pulmonary crippling have the correlation with other echocardiography. It is the diastolic, left diastolic function. So FAC, RVSP, and S prime RVSP ratio have a correlation with LAVI. LAVI is one of the left ventricle diastolic function. Yeah, we also performed a Rockus analysis, but unfortunately the AUC is really low, under 0.7. It's a very poor result. So conclusion, 39 patients with chronic heart failure with reduced ejection fraction. There's no significant association between right ventricular pulmonary crippling parameter with 6-minute walk distance. In examining the relationship between right ventricular pulmonary crippling with other echocardiographic parameters, FAC RVSP and S prime RVSP exhibited a negative correlation with LAVI. They can help us create that the suggestion FAC and RVSP and S prime RVSP could be potential clinical application in predicting early changes on left ventricle dynamics. Thank you for your attention.